Hello, everyone, and welcome to today's webinar in the Public Health Webinar Series on blood disorders. This webinar is presented by the Division of Blood Disorders of the Centers for Disease Control and Prevention, also known as the CDC. My name is Dr. Scott Peslak, and I'm a Senior Fellow and Program Scholar in Hematology and Oncology at the University of Pennsylvania. I also serve as a postdoctoral fellow in the laboratory of Dr. Gerard Blobel at the Children's Hospital of Philadelphia, studying novel regulators of fetal hemoglobin in the treatment of sickle cell disease and in thalassemia. I'm delighted to be with you today to moderate today's webinar, exploring the important topic of evaluating and managing fertility in patients with thalassemia. Before I introduce our guest presenter, I'd like to go over a few points for joining this webinar. Upon joining the webinar, you'll see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If the phone option is chosen, the webinar toolbar provides you with the phone and access number and audio pin. All audio will be muted. At the end of the presentation, there'll be time for questions. To submit a written question, use the questions area of your toolbar, and the presenters will respond to as many questions as time allows. Today's webinar will last about 1 hour, and please note this webinar will be recorded. We'll begin today's webinar with two brief audience polls. First, we're interested in knowing more about you. Please select your response to the poll question below. Which of the following statements best describes you? A healthcare provider, such as physician, nurse, PA, NP, or pharmacist. A public health professional, such as an epidemiologist, social worker, or health educator. A person with thalassemia or family member. Community-based organization, or industry partner. Just give everybody a second to answer. So it looks like we have a mix today, mostly healthcare providers, but also numerous people who have thalassemia or family members, some public health professionals, a few industry partners, as well as some community-based organizations. So that's great that we have a mix, and we'll address a variety of different aspects of care of fertility and thalassemia today. The next poll question, what region of the world are you from? Please select one, North America, South America, Europe, Asia, or Africa, Australia, New Zealand. Another minute for folks to answer. And it looks like the majority of folks today are here from North America, but we have a few from South America, Europe, and Africa, Australia, New Zealand, and several from Asia. So that's great, and we're happy to have you all here and welcome. Now it's my pleasure to introduce today's presenter, Dr. Farzana Sayani, who is Assistant Professor of Medicine at the Hospital of the University of Pennsylvania. And Dr. Sayani also directs the Penn Comprehensive Adult Thalassemia Center, as well as the Comprehensive Sickle Cell Program at the Hospital of the University of Pennsylvania. Dr. Sayani is also a phenomenal teacher and a personal mentor of mine, and I'm very excited to hear her talk today on evaluating and managing fertility in patients with thalassemia. Dr. Sayani, welcome, and let's begin.
Thank you very much, Scott, for the great introduction, and I'd like to thank the organizers for having me speak here today. Today, we're going to, it's really nice to see everybody, and we're going to be talking about the evaluation and management of fertility in people with thalassemia. So I've broken down the presentation in two major topics. We'll be going over what it is, how do you define infertility in thalassemia? What are the causes in thalassemia specifically? What are the indications and outcomes of ovulation and spermatogenesis induction? And what fertility options and what options do people with thalassemia have in starting a family? And then I'll also spend the second half going over pregnancy in thalassemia, specifically talking about the pre-pregnancy counseling and then care and management in the different phases of pregnancy. So to summarize, thalassemia is characterized by primarily an imbalance of both alpha and beta globin chains. And this imbalance, specifically in beta thalassemia, where there's fewer beta globin chains and an excess of alpha chains, leads to an ineffective erythropoiesis. And this is also characterized by anemia due to hemolysis. The ineffective erythropoiesis presents with various complications, including extramedullary masses, bone deformities, osteoporosis. The red cells, since they don't last as long, they hemolyze quickly, also cause anemia. And that increased drive to make more blood cells also results in significant splenomegaly, pulmonary hypertension, increased risk of thrombotic events, legs, ulcers, and fatigue. The increased drive to make more blood, even though ineffective, also increases iron absorption from the GI tract. So iron overload is also a complication. We know that the key treatments are red blood cell transfusions for the anemia, and that results in iron overload causing significant liver disease, heart disease, and various endocrinopathies. And so chelation to remove that extra iron is a key step in management. This shows a cohort of about 720 Italian beta thalassemia major patients who are on chronic transfusion therapy. And we see of all the complications, the most common complication is hypogonadism, due primarily to iron overload. Other complications include hypothyroidism, due to iron accumulation in the thyroid, and then we see arrhythmia and heart failure as also being common due to iron accumulation in the heart. This picture shows the organs that are affected by iron accumulation. There are several organs you may have heard of, including iron accumulating in the liver, the heart, the pancreas, the endocrine organs, the thyroid. But for today's talk, focusing on fertility and pregnancy, we're going to focus on the role of the pituitary, the role of the testes, and the role of the ovary, especially when there's iron overload. The overall survival of thalassemia patients over the years has significantly improved. UK data shows an increase in deaths up until probably the 1990s, with iron overload depicted in red on this graph as being the most common cause of death. However, since 2000, the number of deaths has significantly reduced, and this is primarily due to better control. You can see there is less deaths due to iron overload. We also see that the survival of different birth cohorts has also significantly improved. And these improvements are due primarily to better and safer transfusion therapy regimens, improvement in chelation therapy and options that are available, improved chelation adherence due to the medications, improved methods of iron detection, such as the liver and cardiac MRI, and also overall multidisciplinary comprehensive care. And so with improving survival, more patients are reaching childbearing age. They have improved quality of life. And so the option of having a child, of starting a family, is much more realistic and hopefully much more tangible. We've seen that iron overload does contribute to endocrinopathy, specifically the hypogonadism. This is iron accumulation in the pituitary, which then affects production of sex hormones. Secondary amenorrhea and hypogonadism are the most common of endocrine complications in beta thalassemia major patients. And this is due to iron overload in the anterior pituitary, which is very sensitive. And there's oxidative damage that happens in the anterior pituitary and the shrinking of the pituitary with further increase in iron. And this shrinkage can be seen on an MRI. Other causes of hypogonadism we talk about are, in addition to the iron overload, are hypoxia, liver disease, diabetes, and zinc deficiency. We also know that an increased serum ferritin level is also a predictor of hypogonadism. So if individuals have hypogonadism, they're not producing sex hormones, there is delayed puberty, there's always been a concern about pregnancy. Are individuals fertile? Are they able to have children and start a family? And I'll show you some data. This is the Greek data where they looked at their cohort of patients, and you can see that 72 women were able to have, who had normal menses, delivered. Primary amenorrheic women, those are women who never had their period. 11 of them were able to become pregnant. And in those with secondary amenorrhea, where their period starts, but then later on they sort of lose their period, 17 of those individuals were able to start families. If we look at the Italian experience, we see, specifically focusing on thalassemia major patients, they reported their cohort of 46 thalassemia major patients who had 58 pregnancies. Many of them were able to conceive spontaneously. About 33 of them needed ovarian stimulation. Of those, there were 56 newborns, and most of them had full-term pregnancies, and most of them had singleton births. And so what we can conclude from this data is that pregnancy, what they showed too, was that pregnancy is safe in most women with both thalassemia major and thalassemia intermedia, or non-transfusion dependent thalassemia, and that spontaneous fertility can occur in those individuals who are well transfused and well chelated. What they did find was that those individuals with NTDT who had not received a lot of blood transfusions in the past did develop there was a higher risk of alloimmunization if they required blood during their pregnancy. If we look at the North American and the UK data, there's two publications, one that came out in 2004 and then 2013. And this is the data from the thalassemia, the TCRN, or the Thalassemia Clinical Research Network, which was a cross-sectional registry. It was a longitudinal observational cohort, and they reported 129 pregnancies in 72 women. And what they did find was that women with pregnancy were less likely to be transfused. So if you had non-transfusion dependent thalassemia, you were more likely to be able to get pregnant. What they did comment on was they did notice that in the cohorts from early 2000 to the cohort that they reported in 2013, that there was the number of pregnancies were increasing in their population from 8% to 25%. So that was very encouraging. And what we can see is that, as I mentioned earlier, people who did require assisted reproductive therapy were usually older, and they were also more likely to have thalassemia major. So this data does show that pregnancy can be achieved in individuals with thalassemia major. With improving chelation, with improving transfusion, with improving survival and quality of life, how do we make this possible for all our patients? We know that pregnancies can be spontaneous, or that there are many modalities to induce pregnancies. And so I am going to talk a little bit now about fertility in thalassemia. And to do that, we're going to understand the role of the pituitary in reproduction. So in females and in males, the pituitary controls the release of various hormones, one called FSH, follicle stimulating hormone, and LH, or luteinizing hormone. And these hormones then will stimulate the ovaries in women to produce estrogen and progesterone. In men, the LH and FSH will stimulate the testes to produce testosterone. And so these sex hormones are important for the onset of puberty, for sexual development, and also for reproductive function. So when there is iron overload, as we've seen, the iron accumulates in the anterior pituitary. And so now that high pituitary iron, the shrinking of the volume of the pituitary leads to what we call hypogonadotropic hypogonadism. And now there's no stimulation of ovulation. And so you have decreased ovulation. So the ovaries are not releasing the eggs. There is also thought that iron does accumulate in the ovaries and may affect the development of reactive oxygen species, may also play a role in decreased ovulation in women with thalassemia. If we look at men, the same thing, iron in the anterior pituitary, shrinkage, low volume, results in decreased LH and FSH production, less stimulation of the testes, less testosterone, and resulting in decreased sperm production. But it's known more in men than in women that iron does accumulate in the testes. There's histology evidence of seminiferous tubule deposition of iron. There's NTBI, or non-transferrin bind iron, that also has direct toxic effects on the tissues in the testes. There's also evidence that reactive oxygen species do cause DNA fragmentation of the sperm, therefore resulting in decreased sperm number, but also decreased quality and decreased motility of sperm. And so when we talk about fertility evaluation, it's important to focus on both partners. The WHO describes infertility as the inability of a sexually active, non-contracepting couple to conceive in 1 year. I would say that in thalassemia patients, since we know that they may already have possibly have challenges in conceiving, that number is reduced to 6 months. So if a couple is not able to conceive within 6 months of actively trying, then we should be really focusing on trying to further evaluate the cause of infertility. And this would be involve evaluating ovulation, how it's happening, the efficiency, evaluating the ovaries, evaluating the anatomy, so the fallopian tubes, the uterus, any presence of any fibroids, and then also for men, evaluating the quality and quantity of sperm. And this evaluation is done by both a fertility specialist and or a reproductive endocrinologist. One of the key things is it's important to provide a woman and a man with thalassemia information on their reproductive state, and also for a woman to discuss their plan for pre-pregnancy care, especially since the woman who has thalassemia may have other complications, is going to be carrying a fetus to term for 9 months. And so referral to reproductive endocrinology early on in this counseling is key, and then involving both evaluations in both the patient and their partner. So if they've been on hormone replacement therapy or testosterone, it's important to stop that for 4 to 6 weeks, and then check the production of FSH and LH, estrogen and testosterone levels. This is important to collect, but it's not very reliable in evaluating gonadal function. In women, it's important to check with a pelvic ultrasound to look for the follicles, and also for the anatomy and the tubal patency. And then for males, as we discussed, the semen analysis, but also an evaluation of the testes by ultrasound. For the partner, it'll be important to do a hemoglobin identification to determine what the risk of having an affected child is. And so genetic counseling may also be indicated. Overall, it's important to start assessment, the discussion, the consultation for patients' wishes, for pregnancy, and even fertility preservation early on. If we're talking about fertility preservation, there are also options such as cryopreservation of oocytes and ovarian tissue. But these all take time, and therefore it's very important to start these conversations early. There are no universally accepted consensus guidelines on the management of fertility in general, even in the non-thalassemia population. But there are several algorithms, and we can apply that to our population. We know that most women with primary amenorrhea, so individuals who've never had periods, or secondary amenorrhea where periods stop after starting, will need assisted reproductive techniques. Even though up to 90% of patients may have hypogonadism, the ovaries and the testes are still intact. The problem is the iron in the pituitary, and so the signal's not coming down. But in most of those individuals, the ovaries and testes are intact. And so we can use drugs, and hormones to stimulate ovulation and to also stimulate sperm production. But before we can stimulate the ovaries to produce eggs, we need to also evaluate for ovarian reserve. And a low ovarian reserve is associated with the lower chance for spontaneous pregnancy and poor response to hormonal stimulation. So the antral follicle count, the AFC, and the anti-Mullerian hormone, AMH, are both strong predictors of ovarian reserve. So the AFC is determined by an ultrasound, as shown in the left, where you can see the pool of primordial follicles, and this number decreases with age, as shown in the middle diagram here. You can see that over 30 years of age in women without thalassemia, the follicle count does go down. However, in individuals with thalassemia major, the AFC actually the decline in those follicles is much higher. It's worse, and especially after 30 years of age. The anti-Mullerian hormone assesses through a blood test the ovarian follicle pool, and it also, what we can see that also with age, the AMH goes down, but more importantly, worse iron overload. As that ferritin increases, the AMH also increases, suggesting a lower ovarian reserve. For men, before we can induce sperm production, also important to evaluate the sperm. So a semen analysis. We do know there is evidence that individuals with thalassemia major will have abnormal sperm concentration, quality, motility, and morphology. And this is due to multiple causes. In men, we think of iron overload in the pituitary. We think of iron in the gonads, as we've talked about. But one of the key things, just talking about for infertility in men in general, is the impact of environmental factors. If there's been any trauma, any surgery to the genital area, infections such as mump, occupation, so exposure to jobs that have chemical exposures or high temperatures, tobacco, alcohol, medications, all of these things can contribute to poor sperm production and motility and function. And so those would be important to evaluate in a patient. What was really interesting in a small study showed that transfusions do improve the sperm count and motility acutely. So this is a graph just showing a set of graphs showing day one is before they got their transfusion, and then the second column is those values 7 days after a blood transfusion, and you can see that as the hemoglobin improves, the sperm count also improves as well. We also see a slight rise in testosterone and FSH, but most dramatic was that the sperm count and motility are much better after they received a transfusion, presumably because of the higher hemoglobin. So if we have a good ovarian reserve, or we have evidence of ovarian reserve, then one can consider induction of ovulation. And we could consider induction of ovulation as mentioned in those with primary amenorrhea, secondary amenorrhea, in women with oligomenorrhea, so where the periods are irregular, and can also consider it in women with a normal menstrual cycle who have not been able to conceive despite trying for 6 to 12 months. And then we can also consider induction of ovulation when we want to plan a pregnancy, when there may be a risk of having an affected child. And so ovulation can be induced as well at that point. When we talk about induction of ovulation or spermatogenesis, there's two components. One is induction, so you have to have the production or release of the egg or the sperm. And then there is conception. How do you bring the two together? Excuse me. So for induction, there's different modalities. So gonadotropins, pulsatile, GnRH, and also clomiphene are various modalities that fertility experts will use to induce ovulation. When we talk about conception, this can either be through intrauterine, it could be naturally, it could be through intrauterine insemination, There's also in vitro fertilization, where the egg and the sperm are mixed together in a test tube in the lab. And then you can also have IVF with intracytoplasmic sperm injection. So this is as depicted in the picture here, where a sperm is specifically injected with a very fine needle into the egg. And you can consider this if somebody had poor quality sperm, or if there was pre-genetic or pre-implantation diagnosis, where you could screen to see if there was if there was a risk of an affected child, and specifically identify sperm that way as well. So when we look at induction success, Bajoria et al. Have published some work on induction success when you compare males versus females. They have 15 years experience of 30 couples who had 28 pregnancies. And induction of ovulation was done using gonadotropins. And those gonadotropins are bypassing what the HPG axis. So they're bypassing what the pituitary would normally do. They directly are stimulating the ovary to produce the eggs. And what they did find that there was an 80% success rate within 3 cycles. However, when we look at induction of spermatogenesis, of sperm production in men, this was much lower. It was about 10 to 15%. One of the key things is it can take anywhere from 6 to 24 months of continuously being on some form of therapy for men before one can collect good quality sperm. So it is possible in men. The success rates are lower, and it does take longer time. The fertility is possible if there is preserved ovarian and testicular function, and as we mentioned, much better outcomes in females than men. One of the things that I would mention here for men is that there are recommendations that even if you do get some sperm collected, even though it may not be good, it may be a small number, one may want to consider cryopreservation or sperm banking for the future. So that's something that can improve the success of future pregnancy. There are several fertility options, and really this depends on where the problem is, where the site of damage is. So if the damage is because of iron overload in the pituitary, and the pituitary is not able to send down a signal to the ovary or the testes, then we talk about induction of ovulation or spermatogenesis with hormonal therapies. But if there is primary ovarian or testicular failure, so for whatever reason the ovary is not responding, there is no ovarian reserve, or there is no sperm production, then an egg or sperm donation may be options. The fertility options that we pick also depend on the carrier status of a partner. So if both partners are homozygous, so if both partners have thalassemia major, they're going to have 100% chance of having a child with a thalassemia major. And if their choice is not to have a child with thalassemia major, then sperm or egg donation can be considered. If the partner is a carrier and there is a risk of having a child that's affected, then pre-implantation genetic diagnosis can also be considered. One of the key things to remember is that adoption is an option in all of these cases when one wishes to start a family. So with that, I'm going to move on to pregnancy. So somebody may be ovulating, a woman may have regular periods, or even if they don't have regular periods, or a man is not able to produce sperm, that we do have therapies that are available that can stimulate ovulation or spermatogenesis. But how about the woman getting pregnant, an individual with thalassemia becoming pregnant? And the most important fact, if you're going to take anything away from this talk today, is that our goal is for a planned pregnancy. And a planned pregnancy allows us to evaluate the mother, and hopefully the goal being to reduce any complications to both the mother and the fetus. So for pre-pregnancy counseling, it's really important to start discussions early to minimize the risk to both the mother and the fetus. We need to discuss the overall health of the thalassemia patient. We also need to talk about the risks of induction and the medications. We also need to talk about risks of pregnancy. What about the psychological impact, the emotions that go around wanting to be pregnant, wanting to start a family? How about the risks, the anxiety, the stress? And also the thalassemia genetics of each partner, and that needs to be discussed. What about the cost? These IVF treatments, hormonal treatments are not cheap, and in some cases, insurance may not be able to, we may not cover them. And then ethics, the ethics of it, and this is a very personal decision, and something that also needs to be brought up so that a couple can begin to have these discussions early on. When we talk about risks to the mother, one of the key things is cardiac function and the risk of cardiomyopathy. The cardiac load during pregnancy increases by about 25%. And so if there is a pre-existing cardiac dysfunction, and we expect there's going to be worsening iron burden and transfusion volumes during the pregnancy, this can lead to serious cardiac complications and even death. It is also important to talk about the risk of development of new endocrinopathies during pregnancy, including diabetes, hypothyroidism, hypoparathyroidism, which may have an impact on the course of the pregnancy and also impact on the fetus as well. There is going to be increasing iron burden. This is because the transfusion requirements go up in order to maintain a high enough pre-transfusion hemoglobin during pregnancy. And ferritins can increase by up to 60%. There's also an increased rate of C-section of about 85%, and some of this is because of the craniocephalic disproportion. So a woman's pelvis may be small and not large enough for the baby's head to go through. And then there's also an increased risk of thrombosis or blood clots that goes along with being pregnant, but also thalassemia increases your risk of blood clots. And then the whole stress of being pregnant, worry for both the mother and the baby, and the increased risk of anxiety and depression. To the fetus, in the data that we have, some of what I presented earlier, there was no increased risk of miscarriages. There was no increased risk of malformations. There was growth restriction of about 4 to 8%. There was an increased risk of preterm labor. And then because of induction and therapies, there may be an increased risk of multiple births, so twins. And so we know that we're starting the conversation. It's important to start the conversation early. But what do we do for preconception counseling? And the key things to focus on are iron burden. We've heard about the cardiotoxicity, the cardiomyopathy, and the high risk of mortality if there is significant cardiac iron. So evaluating iron burden, assessing the complications that the future mother may have, reviewing medications, and then also genetic screening. When it comes to iron burden, aggressive chelation preconception is very, very important, and I cannot stress this enough. And the key goal is to reduce the iron burden, and would say to a liver iron of less than 5 milligrams of iron per gram dry weight. You'll see reports of less than 7. There really is no clinical trial or comparative data, but I would say that most of us would try and aim for the lower the liver iron content, the better. We want normal liver enzymes, normal abdominal ultrasound, and then also aiming for a cardiac T2 star greater than 20 milliseconds. so that there's no iron or no evidence of cardiac iron, and normal left ventricular ejection fraction of greater than 65%. We do know that a low heart function, so a low ejection fraction, is a relative contraindication to pregnancy. In the past, if we look at old data and also old clinical experience, before we had modalities to measure heart iron, there were many individuals who succumbed to cardiac death during pregnancy. And so even more important for us to really chelate aggressively before trying to get pregnant. Assessing complications, if somebody has endocrine complications like diabetes, hypothyroidism, osteoporosis, it's important that these are identified and that they're followed with an endocrinologist and monitored closely, and that all of it is optimized. It is also important that transfusions, so pre-transfusion hemoglobins before conception, are maintained over 9.5 grams per deciliter. And then assessing the status of viral infections, ensuring the HIV, Hep C, Hep B, and rubella status is known, ensuring that they do receive and have received their hepatitis B vaccination, and also splenectomy vaccinations if they were not done and they have had a splenectomy in the past. Also important to ensure that liver enzymes are normal, and also ensure that the blood pressure is normal as well. Important before one attempts to get pregnant to also review medications. The oral iron chelators are contraindicated in pregnancy. And so generally we say we try to avoid using iron chelators during pregnancy, especially the oral chelators. And if we were talking about desferal, we would say the general recommendation is to avoid any chelation, especially desferal and the oral chelators in the first trimester. Desferal has been shown to affect, to have skeletal anomalies in mice, but they are individuals where we've used desferal in the second and third. But the key thing is if we go in, if an individual goes into a pregnancy with very little liver iron and no cardiac iron, then they're more likely able to get away without needing iron chelation. Also important to discontinue bisphosphonates 6 months prior because we want to try and get pregnant, stopping hormonal replacement therapy. If they've been on an ACE inhibitor for blood pressure control, that needs to be stopped because that can affect kidney formation. And there's also starting folic acid 3 months pre-conception. We talked about preconception genetic screening, where the partner is screened, and the role of genetic counseling, and also talking about the methods and risks of prenatal diagnosis, and if there is a high risk for an affected fetus, considering pre-implantation genetic diagnosis to increase the likelihood of having an unaffected child. So what about when we finally do get pregnant, when the patient with thalassemia is pregnant? For transfusions, in somebody with transfusion-dependent thal, the recommendations are generally to maintain a pre-transfusion hemoglobin greater than 10 grams per deciliter. Some will even go as high as 11. Usually, as the number of transfusions increase, especially as we go into the second and third trimester. For non-transfusion dependent thalassemia individuals, the hemoglobin will likely decrease through the course of pregnancy, especially into the second and third. And transfusions would be indicated if the anemia is worsening or if there is evidence on ultrasound of growth restriction. And generally, transfusions are needed in about 60 to 80% of patients. So when it comes to iron overload, as I've mentioned before, the preconception goal is to aim for a T2 star of greater than 20 milliseconds of normal heart function and an liver iron less than 5. And if we had this, then generally we would say no chelation is required during pregnancy. However, if one does have to use chelation, we need to tailor the iron chelation, We know that oral agents are contraindicated, and deferoxamine can be used in the second or third trimester, and that there are no because there's no reported adverse outcomes in the late second or third trimester in various case series that have been reported. This is one, there are several, but this is a reasonable approach, is to focus when you're determining whether somebody does need chelation during pregnancy. We talk about following the T2 star if it's greater than 20 milliseconds or less than 20 milliseconds. If there's no cardiac iron, but there is liver iron, then one could consider chelation with desferal after 28 weeks. If there is iron in the heart, then definitely consider deferoxamine starting in the second trimester. And a lot of this comes down to risk and benefit and evaluating how comfortable does the couple and the mother feel, but also evaluating the risk of potential cardiac toxicity and cardiac complications during pregnancy. Prenatal care is a multidisciplinary team approach. Really important to evaluate with regular echo, EKG, and clinic visits initially at 28 weeks and then as needed. Endocrinology monitoring for diabetes with the oral glucose tolerance test, thyroid function as well. May consider thromboprophylaxis with aspirin or low molecular weight heparin in certain circumstances, and then for fetal growth, starting ultrasound monitoring and closely working with MFM. During labor, the timing and method is per obstetrical guidelines. Vaginal deliveries are not contraindicated. And during labor, they may generally try and keep the hemoglobin over 10 grams per deciliter. If there was worry about iron in the heart, Porter et al. Recommended desferal 2 grams IV over 24 hours given during labor, and then important to closely monitor with electronic fetal monitoring. Postpartum, there's a high risk of venous thrombosis, so the general recommendation is for low molecular weight heparin in the hospital and for 6 weeks postpartum. Breastfeeding is safe and should be encouraged. Desferal is okay to use. It's secreted in the breast milk, but it doesn't get absorbed. It's too large of a molecule, and we really don't have any safety data on oral chelators. We generally talk about contraception, and then I evaluate for iron burden, usually at 6 to 8 weeks, and then discuss when to start chelation. So to summarize, I think the key points are chelate, chelate, chelate. Management of iron burden is key to both pubertal development, fertility preservation, and safe pregnancy. And there are many options to starting a family, including ovulation, spermatogenesis induction, egg sperm donation, and even adoption. And pregnancy in thalassemia patients is possible. It's safe. It usually has a favorable outcome with a comprehensive multidisciplinary care. And we do need to be aware that there is a potential for life-threatening cardiac complications, and therefore really important to optimize the cardiac function pre-pregnancy. And we should all remember that family planning and pregnancy are emotional topics. They're very personal topics. They cause anxiety, stress, and depression. And thus, it's very important to address these topics with sensitivity and compassion. It's important to provide psychological support to the couple and to also encourage group support, to encourage patients to reach out to other patients who may have gone through what they're going through, and to really take advantage of organizations like the Cooley's Anemia Foundation to really look for that support. And with that, I would like to thank the Cooley's Anemia Foundation and the CDC for inviting me to present on this very important topic. And we'll now be open to taking any questions. So feel free to enter those questions in the chat box, and we'll go from there.
Great. Thank you, Dr. Sayani, for a really fantastic presentation. As Dr. Sayani said, we're going to shift to the Q&A section of the webinar. Again, if you have a written question, use the question toolbar, and I'll address them in the order we get to. We should be able to get to all of them, hopefully. The first question we had, Dr. Sayani, was a question about how to basically help young patients plan for fertility in the future. And I know you addressed some of this in your presentation, but specifically, when should they go to an MFM provider or an OB-GYN, and also what kinds of contraception would you recommend prior to when they're ready to become pregnant?
I think that a lot of these conversations also can start in in pediatrics, and there we're talking not necessarily about having children or the details, but just trying to talk, focusing on puberty as well. And I think that's where the discussion of iron chelation, the sooner we talk about importance of iron chelation and normal pubertal development, the better. But if we're talking about somebody who's post-puberty, I think the earlier we discuss it, I think it's important for a provider to bring it up. And if the provider doesn't bring it up, for the patient to bring it up in discussion, to reach out to a gynecologist or an obstetrician to get some, you should be getting the initial testing. And somebody may not be, you may not have a partner at the particular time, but if the desire is to one day have a child, to start a family, then I think it's never too early to begin that conversation.
Yeah, great. A couple of questions about tying into that, about pre-pubertal fertility preservation in patients either undergoing transplant or, in terms of gene therapy with alkylating conditioning agents, and just wonder your thoughts on that as well.
So this is an area that so there isn't much that's been done in thalassemia. I think but if you take cancer, there's a lot more experience in the oncology section, where young individuals going through chemotherapy or going through bone marrow transplant for leukemias, lymphomas, et cetera, that area has been very well developed. I know here at Penn, the bone marrow transplant team works very closely with our fertility preservation group, and we reach out to those individuals as well when we're now talking about fertility preservation, whether it's for bone marrow transplant for thalassemia or for gene therapy. And I think that is something to definitely discuss, to bring up with the fertility preservation. Which one to choose will also depend on the age. There's a lot of testing that goes with that. There's cost. Different procedures have different costs. So these are, and then also the success in the future. So there are reports of some thalassemia patients, and more so in the oncology area, where they have had successful pregnancies using the cryopreserved tissue or oocytes. And so it is something that is available, and I strongly encourage you to reach out. And this can be done and really gather the facts. I think it's a very personal decision, and really get information.
Great. There's a question about, in terms of the endocrine follow-up, the kinds of tests that you would recommend to follow, as far as thyroid testing, testing LH and FSH, things like that. And I just wonder if you want to comment on the kinds of testing and the frequency that you do for that.
Yeah. So for endocrine testing, we check all organs. The recommendations are for screening. We do this once a year. So TSH for the thyroid function. We also for transfusion-dependent thalassemia, we do recommend a fructosamine, but then also important to do a once-a-year oral glucose tolerance test. That's a better screen for early onset of diabetes. We also recommend LH, FSH screening and testosterone levels in men as well too. And if testosterone levels are low, that warrants treatment. We also check for AM cortisol and ACTH, and also parathyroid hormone. These are all done once a year. And then for bone health, vitamin D is also important.
Great, thank you. There was a question from the male side of sperm banking and storage, a question of when you would start doing semen analysis potentially, and at what age would you start thinking about sperm banking? I'm just wondering your thoughts on that too.
So I think if someone is interested in identifying that, yes, an individual wants to start a family, I think the sooner the better. So if we know that there's various factors. if someone is well chelated and has low liver iron, low cardiac iron, they probably will be okay compared to somebody who has high liver iron and high cardiac iron, and potentially their sperm production is most likely going to decrease over time, and that's what the data has shown. So I think that if the sooner the better, I would say if somebody, if we're talking about young adults or adults, if you're able to collect some sperm and save it, and you may not need it. You may not need it for the future, but if you do, then at least it's there.
Great. There's a question on here that I was actually wondering myself is, since the follicle counts go down after 30 by the graph for Thalassemia patients, is this something you would think about doing, freezing, embryonic freezing or egg freezing or ovarian harvest before that, to be able to make sure you preserve fertility later in life if women are planning on having children later in life?
I think these are all very, very good questions. I think one needs to weigh the risks and benefits. One needs to weigh the costs. I think, yes, the data is there that the older you are, the less ovaries are available. And so I do encourage individuals to talk it through, refer them to a fertility specialist if they were interested. I think very often there are the medications that go with ovulation induction are associated with complications, hyperstimulation, ovarian hyperstimulation. And so those are discussions to be had. I think we also need to think of the cost of storing these as well. And so I do recommend it if people are interested. But at the same time, with new advances in fertility treatments, I think that the outcomes, we're also showing better outcomes with regards to ovulation induction and the contraceptive methods that are available. And this sort of stresses, all of you bring up some excellent questions. And these are all technologies that are available. Are they right for everybody? What is everybody's individual circumstance? What is the liver iron, cardiac iron burden? What is somebody's personal life, partner, no partner, school, going to school? When do you think you might want to start a family, relationships? I think these are all in cost, or even the ethics of it. And so it's really important to start these discussions early. And depending on what an individual is going through at different points in life, it will also affect their decision making. And having these different tools, I may refer somebody to for counseling to a fertility specialist, but it may not be the right time, or their life circumstances may be very different. But maybe 2 years from now, their personal life or their partner or work may be different. And so they would ask different questions. So I think the key take-home message is there are resources available out there. There's technologies. We need to start the discussion early, and we need to make sure that patients are in the best shape possible so that when they are ready to start their family and they do want to try and conceive, that they're in the best shape and they're set for success.
A couple of interesting questions about whether there have been seen any differences in pregnancy outcomes as well as long-term complications in different ethnic groups. And I don't know if we have the data on that necessarily larger, but just in your experience, have you seen differences in terms of both being able to conceive and also complications during and after pregnancy?
Yeah, that's a very good question. From the data that's been presented, there are different cohorts, Greek, Italian, North American, but I would say that the North American UK is probably the most diverse group. but there is no comment or there's no discussion on racial disparities or any racial breakdown.
In terms of one of the other questions, in terms of male chelation, is there any recommendations to change or hold chelation for men who are trying to conceive?
Yeah, so there are no recommendations that I'm aware of for men. I think that if one wanted to be safe, transitioning to Desferal, for women, we say stopping Deferasirox 3 months before and Deferoprone 6 months before and transitioning to Desferal prior to conception. I think that for men, it would be reasonable to change to Desferal, but again, keeping good adherence, continuing to do good chelation and keeping the iron levels low is the most important. Sometimes what happens, we just need to be careful, is that while we're trying to conceive and conception, it can take a long time to be successful. We just want to make sure that the ferritin doesn't start to creep up and the liver iron doesn't start to creep up while we're reducing or changing the chelator that we're on.
Yeah, thank you.
So I would recommend, for my patients, if they were trying to conceive, to change for men to change to Desferal, as long as their other parameters were fine.
How about the Feriprox? Is that something that is usable?
Deferoprone. Deferoprone, there is some data in animal models that it is teratogenic, and so I would avoid Deferoprone. We have more information on the fetus and the mother being on chelation or not. There's some there's animal models of pregnancy and effects on the fetus, but that's usually implied the mother. I don't think we have data on sperm and DNA damage and how that affects the fetus. I just don't think that there's enough information.
Yeah. And then on the endocrine side, there's a question about doing DEXA scans and how often we do them, and also whether they're valid and usable in patients with a significant amount of extramedullary hematopoiesis, and how that kind of affects the interpretation.
Yeah, that's a very good question. I do think that if somebody has significant extramedullary hematopoiesis, we think about it, it likely does affect it, but we just don't have data. And the best thing we have is the DEXA scan. So yeah, I think we need more study. There are other methods that I know in terms of osteoporosis. It'd be, other MRI techniques. I think those need to be validated in thalassemia, especially. It'd be interesting, this very question being asked and using these specialized new MRI techniques. They're new advances, but the best thing we have right now is the DEXA scan. I think it'd be also, be valuable if we had any correlative data with biochemical markers. But I think the best, when we talk about osteoporosis or low bone mineral density, really, if somebody has a lot of extramedullary hematopoiesis, controlling that with transfusions, you're still going to need the transfusion therapy to suppress the EMH. You're still going to need therapies to optimize the bone health, so whether it's vitamin D or potentially bisphosphonates. And so any modality, we're going to use multiple modalities to improve the bone mineral density. But it's a very good question, and I think an area where we still need further study.
Right. I just want to say we've gotten several questions for patient-specific questions. We can't really answer that in this forum, as we don't have full access to the patient's records and medical history, but we would suggest you talk directly with your treating physicians, whether hematology or our gynecologic and MFM providers, about your specific cases and questions. All right, I think that's unfortunately all the time we have today. Some really great questions. I just want to thank Dr. Sayani for really this valuable information she's given us on a topic that's really important to our adult patients with thalassemia, and thank everyone here for joining us. If you want to go to the next slide, Dr. Sayani. We also want to thank our colleagues at the CDC's Division of Blood Disorders for this invitation to be with you all today, as well as the Cooley's Anemia Foundation for hosting this webinar. Very shortly, you're going to receive an email asking for your feedback, so please respond with any comments you have. And if you have additional questions about today's presentation, please contact Cynthia Sayers at csayers@cdc.gov. That's CSAYERS@cdc.gov. And if there's things that weren't answered, we can address them there as well. This webinar will be archived, and the content will soon be available at the CDC Division of Blood Disorders website, as shown on the slide here. And then finally, on the next slide, please join us next month on December 10th, when we'll learn about new treatment guidelines for hemophilia from the World Federation of Hemophilia. And thank you all for joining us, and have a great afternoon.